afternoon. Thanks for having us here today. My name is Amy Morrison. This is Peter Dominguez. We're fourth-year medical students at the University of Central Florida. Today we'll be presenting a case from the Orlando VA Medical Center called Recurrent Abdominal Pain of an Unexpected Source. In this case, a foreign body was ingested in our patient and proved to be a difficult diagnosis. So for background, ingestion of a foreign body may lead to several and many potentially lethal GI complications, such as inflammation, obstruction, perforation, and hemorrhage. However, despite the potential for these serious complications, foreign body ingestion is often not considered for many reasons. It often has variable onset, non-specific symptoms, and may not come up when taking a patient history due to them not recalling the ingestion. Our patient is a 74-year-old male who had been admitted multiple times over the prior 4 months. This was his third hospital admission where he complained of intractable bilateral lower abdominal pain exacerbated by bowel movements. Abdominal exam was significant for diffuse tenderness to palpation in the bilateral lower quadrants without peritoneal signs. He notably had a normal white blood cell count. The CT from this admission is noted in Figure 1 in the bottom left corner. The black circle delineates a small fluid collection with surrounding inflammation in the ileum and central mesentery. This had been present on prior imaging. However, he was treated conservatively with antibiotics at those times. As the patient's symptoms had not fully resolved at this admission, the patient was started on IV Zosyn with plans for surgery. The patient underwent a diagnostic laparotomy with small bowel resection and primary anastomosis. During the surgery, a toothpick, fully intact, was found perforating the ileum and walled off by omental, colonic, and mesenteric adhesions. The patient did not recall any accidental ingestion.
So as you can see in Figure 2AC, in the center column shows gross specimens of small bowel with focal perforation, along with a fully intact toothpick. Microscopic exam showed in Figure 3AB confirmed a perforation with significant transmural inflammation. The patient's clinical course improved after the surgery. His diet was advanced and his bowel function returned appropriately. But on post-op day 8, a superficial wound infection was noted, and the patient was discharged from the hospital close follow-up in the surgery and wound care clinics. There are a few takeaways we wanted to point out from this case. The first, although often forgotten about, foreign body ingestion should be considered as part of the differential diagnosis in patients with intractable abdominal pain, ileitis, or acute abdomen. This case also highlights that perhaps earlier surgical intervention should be considered in patients who have waxing and waning abdominal pain and associated imaging finding in a recurrent area. Lastly, we encourage practitioners with high clinical suspicion for ileitis secondary to a foreign body to engage in further questioning about possible ingestion. We want to give special thanks to co-authors and our supportive faculty, Dr. Jonathan Vazquez, a pathologist, and Dr. Minh, an infectious disease specialist. We will take questions at this time.
All righty, thank you both so much.
Thank you.
Thank you.
I think we can go ahead and move on to the next presentation.